I will send out this to everybody as a PDF, and I'll also post this to the scconsults.org website under the didactics tab. So we'll make this available. And I'm always here to send emails to if you have questions about any topic. But I chose to talk about complementary, alternative, and nutritional treatments for schizophrenia spectrum disorders. And the reason that I chose this is because this is there are reasons to do this, to pay attention to this. Most importantly, because they're popular and they're accessible, and they represent, in the minds of the public, potentially credible alternatives to customary treatments. Customary treatments, which unfortunately do come with well-documented risks of side effect, and which unfortunately historically have, at least at times, been prescribed in doses that are excessive and under conditions in which choice has been limited. So they have all those things: side effect profile, history of forced use, and overdosing. Overdosing of medicines leads to, say, a bad taste in the collective mouth of the public, or contribute to a bad brand image for this category of medicine. So people are very much interested in alternatives for that. Also because the customary treatments, even though there may be 20 different antipsychotic drugs, they really are just various flavors of dopamine receptor blockers. So they target one pathway under the category of drugs that have FDA approval. And there is a really important need for expanding the range of therapeutic targets to the extent that there are worthwhile targets that don't involve dopamine. I think it's useful to know about that. And again, because of A and B, people are interested and they can get them. So your patients are likely to be using them whether they tell you or not. So knowing a little bit about this topic, I think, will be helpful for several of those reasons. And despite the importance of this, I mean, that you might have treatments that can target entities other than the dopamine receptor that may have entirely different and usually benign side effect profiles. Despite all those reasons for being interested in them, the research on this topic is just painfully small. There are lots of barriers to getting a robust rationale for introducing these into practice. Some of them have to do, I'm going to lay blame with the NIH and its way that it does business. For 10 years or more, NIH says we're no longer going to be interested in clinical studies, we're going to be interested in basic science or mechanism. So then looking at, say, omega-3 fatty acids as a treatment for schizophrenia is a clinical study and it doesn't answer basic science questions, so it's deprioritized. And all these natural products, anybody can do them, study them, and so they've been, to some extent, studied before, so they no longer look novel. And NIH will deprioritize studies that aren't groundbreaking. So getting funding for doing this research is quite difficult. Industry is not interested in sponsoring this because all of this stuff is not patentable. Well, we can make an exception for Epidiolex, which we'll talk about down the road here. But by and large, these are not patentable products, so profit can't be made. And so to do the very expensive randomized, double-blind, multi-site studies that were required to get official recognition, it just doesn't happen. And speaking of official recognition, there is no entity other than the FDA that really signs off on approaches. So we don't have anybody to ring a bell for when it's okay to use something. So today we're going to do a fast overview of some of the entities that I have some familiarity with and that have some literature to support their use. These are the entities we're talking about: omega-3 fatty acids, N-acetylcysteine, melatonin, Cannabidiol, aka CBD, and dietary interventions. And this is, I mean, we could probably do 50 minutes on just one of these topics. So this is going to be a fast tour of some options. So starting with EPA, the omega-3 fatty acid. Omega-3 fatty acids represent a family of fatty acids. They go from short to long. EPA is the longer end of the spectrum. EPA comes from fish or from algae, which fish eat. That's pretty much the only way you get EPA. Humans, there are theories about human evolution that suggest that we evolved near sources of fish, and that was a major contributor to our diet. Estimates from Paleolithic societies or current Paleolithic-like societies believe that human diet is optimized for about a 1-to-1 or a 4-to-1 ratio of omega-6 to omega-3. So the original diet of human was thought to be very rich in omega-3 fatty acids. Modern estimates of diet say that the omega-6 to omega-3 ratio has risen to between 20 and 40. So we're a long way from Kansas. And there are theories that suggest that deviation is relevant to a whole host of mental status, mental illness, and mental functioning issues. Nuts contain an omega-3 precursor, but it's difficult to go from the short side, like ALA, to the long side, like EPA. Some people actually have genetic mutations which make that process extremely slow. So if you don't get EPA from dietary sources and you have certain genetic variations, you might actually run deficient. And scientific investigations of people with schizophrenia suggest that there is a deficit in these longer EPA, in these longer omega-3 fatty acids like EPA or its cousin DHA. EPA is important because it is, broadly speaking, has anti-inflammatory capacity. And there are theories of psychosis that say that inflammation or abnormal inflammation can create mental illness or psychotic states. EPA also inhibits an enzyme called phospholipase A2 at, let me rephrase that, pharmacological doses of EPA, and by pharmacological doses I mean about 2,000 milligrams. Those actually inhibit that enzyme phospholipase A2, and several lines of research say that PLA2 is overactive in at least some people with schizophrenia. So that's the rationale for why EPA might be helpful. The empiric data consists of at least some of these studies. I apologize, I didn't know they were going to come out with the hyperlinks in blue. It didn't look this way on my screen. So you'll get the PDF. All those underlines are hyperlinks to the original studies. So if you can review them at your leisure. But the summary, I mean, the most interesting one is the top bullet point. There's a case report of a young man who had been ill with schizophrenia, well-diagnosed, well-characterized schizophrenia for 4 years. He had one bad experience with traditional antipsychotic drugs, swore them off. Eventually, though, he was agreeable to a therapeutic trial of EPA at 2,000 milligrams a day, and he was a regular participant in non-pharmacological studies at King's College in London. So they did characterize him very well. He went from a PAN score, I want to say around 90, to a PAN score of 30. Essentially, he was in remission, and he stayed in remission for some time. I wrote to the case report author, Basant Puri, and asked whatever happened to that guy, and Dr. Puri responded and said that this individual maintained 4 years of continuous remission from psychotic symptoms. He was doing so well that he decided to stop taking the EPA, at which point the psychosis came back, and then he was hospitalized and he was lost to follow-up. So, I mean, I hope that Dr. Puri will publish that, because that is a very interesting and, to my mind, compelling end to that story to suggest that EPA in that case was actually legitimately effective. It turns out, I mean, I learned something new. I didn't know that the American Psychiatric Association, I didn't know until yesterday that the American Psychiatric Association had a subcommittee to investigate omega-3 fatty acids and to make recommendations as to their use in psychiatric conditions. They, in fact, did convene such a committee, and the committee voted, and the APA endorses the findings that say that EPA should be part of psychiatric treatment. From the paper, whose reference will be in the next slide, these are some results of meta-analysis in which the squares and diamonds on the right represent the mean and the confidence interval around the mean difference in PAN score. So every one of those bars, all but one of those bars shows that the mean is to the left of the 0 point. So all of those data are studies of omega-3 fatty acids, EPA and or DHA, in people with schizophrenia, and altogether there's a signal for efficacy. And incidentally, the mean difference in PAN scores is much larger in this study than the mean difference in PAN scores for a CBD oil study that I'll talk about down the road here. So this leads to official endorsement that patients with mood, impulse control, or psychotic disorders should consume 1 gram of long-chain omega-3 fatty acids per day. And they note the FDA has said that up to 3 grams per day of such supplements are considered safe. To my reading of the data, I would rephrase that for schizophrenia care, it should be 1 gram, it should actually be 2 grams of EPA. The evidence is much stronger for EPA versus DHA, but clearly there's a signal for efficacy, and there's no significant toxicity. To my mind, is now, I joined the American Psychiatric Association in saying anybody with a psychotic disorder should be on that. So turning now to N-acetylcysteine. N-acetylcysteine is a simple derivative. I call it semi-natural because they take acetyl groups, which the body makes in abundance, and it attached to cysteine, which is an amino acid that we use for protein synthesis, and there you've got the drug, acetylcysteine. Acetylcysteine functions as the primary precursor for glutathione, and glutathione, as probably many of you recall, is the body's primary antioxidant molecule. So in addition to being a precursor to glutathione and having pharmacological doses boost glutathione levels, N-acetylcysteine also has the ability to modulate the neurotransmission signaling of glutamate. So N-acetylcysteine also functions as a glutamate modulating drug. And this is interesting because in schizophrenia, there's evidence that there is increased oxidative stress. So particularly the data suggests at early phases of illness, the body is creating a lot of oxygen-free radicals that exceed its capacity to neutralize them. So adding more glutathione to that mix theoretically would be helpful. That has yet to be proven. But there are glutathione depletions that have been shown in early stage psychosis. The part that's missing is the extent to which NAC can reverse that. There are also abundant evidence that of glutamate signaling abnormalities. There may in fact be an entire subtype of schizophrenia, which probably is better called glutamate psychosis. There's evidence that in schizophrenia are 2 pathophysiological pathways with which N-acetylcysteine can interact potentially favorably. There are a total that I could find of 2 studies of NAC in schizophrenia care. Both, to the credit of the authors, were done against placebo. Both were adjunctive studies. This one is by Burke, and both studies actually are going to show similar findings. Essentially, everything gets better except positive symptoms, particularly the negative symptoms or the total pathology level goes down. In this study, also akathisia went down. But there was no budge on the positive symptoms. So this is a Burke study. This is a Farrakina study. This was done in Tehran, and similar finding. Adjunctive NAC versus adjunctive placebo, decreasing total PANS, decreasing negative symptoms. Well, I didn't write that there, but negative symptoms went down. No effect on positive symptoms. So that's your data on N-acetylcysteine. There is a, maybe not all good, I get, fortunately, many people with schizophrenia tell me about their experiences. One such individual learned about NAC on her own accord and tried it, and actually found a recurrence of hallucinations where she had been stable for quite a long time on clozapine. So with anything, pay attention to what happens and shift strategy if it goes the way opposite of what you imagine it to be. As an aside, I want to just let you know about these 3 pieces of evidence that suggest that N-acetylcysteine can be useful at negating self-injurious behavior in people that are regularly engaged in self-injurious behavior. We have 2 case reports and 1 open-label group study. In the first one, if you're super interested, email me and I'll send you the English translation of this Dutch report. But it describes a 17-year-old woman who'd had a long-standing cutting of arms and legs, and essentially she went into remission from that behavior after NAC. The second came from a group from Yale that were interested in glutamate signal modulators as a potential treatment for self-injurious behavior. They described a case where there was remission of the urge to engage in self-injurious behavior. Other symptoms like depressed affect didn't change, just the urge to cut went away. And then in this last study by Cullen, in a group study, overall there was a reduction of the average signal for self-injurious impulse and self-injurious behaviors at a group level. So again, nobody's going to patent NAC because it's a generic drug. So you're not going to see a pharmaceutical company taking this up, and progress in this area is going to be slow if progress happens at all, but pay attention to that space. Melatonin, also, as you know, natural product. You might not know that in rats, melatonin really quite reliably can be a slimming drug, especially if you make the rats fat by overfeeding them with sugar or with fat. It may be that effect of weight reduction in rats may result from the fact that melatonin in rodents can cause browning of adipose tissue. So it can convert white fat into brown fat. Brown fat engages in futile energy cycles. It just basically burns calories and generates heat in the process. Whether that happens in man is a very good question. Studies of melatonin and schizophrenia are limited. There is a signal that it may improve sleep quality, which isn't a bad thing at all. There is this very interesting study also coming from Tehran, and as an aside, I find that most of the very interesting work in cutting edge use of off-label or repurposing of drugs comes out of Iran these days. So kudos to our colleagues there. But in this study, they took individuals with recent onset schizophrenia, all were treated with olanzapine, and they were randomized to adjunctive melatonin, adjunctive placebo. They found that the melatonin was able to mitigate the weight gain. So there was ultimately like a 7-pound difference in the average weight of both groups at the end of the study. And amazingly, 12-point mean difference in PAN scores between groups. So it actually they had greater resolution of psychotic symptoms or in the melatonin treatment group. 12.9 as a mean difference in PANS is really quite remarkable for a study with that design. Meanwhile, however, meta-analysis of 5 studies didn't show, on average in the meta-analysis, a clear signal for efficacy. It did support the idea of at least a possible role at mitigating weight gain. So with melatonin, you have a drug which is very low toxicity, which has a probable ability to improve sleep quality, and at least in sub-studies, perhaps in some populations, an ability to further improve psychiatric symptoms. Turning now to cannabidiol. Cannabidiol, very, very much in the press. We were joking here before the study that is touted as a cure for almost everything these days. Cannabidiol, I'll say CBD because it's easier, is a component of hemp, and it is minimally active at engaging the brain's cannabinoid receptors. So it binds to it. If it binds to CB receptors at all, it binds very weakly, appears not to turn them on. What CBD is able to do is enable to inhibit the degradation of the brain's endogenous cannabinoid called anandamide. So we make anandamide in our brains. Anandamide, according to human literature, seems to serve an anti-inflammatory purpose in the brain. Incidentally, exogenous cannabinoids like THC, so smoking pot, in human studies has been shown to greatly reduce anandamide levels in the brain. So a theory for cannabis-induced psychosis is that exogenous cannabinoids suppress the brain's endogenous anandamide, rendering it more vulnerable to inflammatory insult. And at any rate, CBD is an anandamide-preserving drug. And it's equivocal in my view. These are the studies that I could find that are worth commenting about in CBD for schizophrenia. The top line from McGuire got published in the American Journal of Psychiatry. They show a mean difference in PANS of 1.4 points between CBD group and placebo group. It met statistical significance, but a mean difference of 1.4 PANS points is quite small. Keep in mind that the PANS difference for the melatonin was 12, and the PANS difference from the EPA, some of the studies were 10. So nonetheless, it's heralded as a finding of statistical significance, though in that study, functional outcomes didn't improve and neither did cognition. In the next study published this year from Boggs Group, looked, and they found no difference versus placebo. They actually found cognition in the placebo group was better than cognition in the CBD group at the end of the study. The most interesting study of the group was the one by Levecki in 2012. It's a reasonably designed study, and they found that PAN scores were markedly reduced, a 30-point difference from baseline to endpoint in the CBD group. Interestingly, they also looked at serum levels of anandamide, and they found that the patients that were getting better were having anandamide levels go up. So again, CBD looks like it is an anandamide preserving drug, and anandamide might be useful as an antipsychotic agent. So the Levecki study, I think, points the way to perhaps a rational study design. To my mind, screening people for anandamide levels at baseline, then randomizing them to CBD or placebo might be the best test of CBD efficacy. And then finally, the last study is Zuardi. It's just a case series of 3 people with treatment-resistant schizophrenia. Only 1 got better, and that improvement was described as mild, and 2 didn't get better. That was in a treatment-resistant group, so I think it's difficult to interpret the significance of those findings. Now, pay attention to the middle column, dose and duration. Doses of CBD, 1,000 milligrams, 600 milligrams, 800 milligrams, 1,280 milligrams. That's the range that they're looking at for CBD efficacy studies in schizophrenia. If you want to negate the anxiogenic effects of marijuana, 30 milligrams works. If you want to negate the psychotic-genic effects of THC, and they've done these studies to show that THC can induce psychosis-like experiences, 200 milligrams get you there. But if you want to treat schizophrenia, we're looking at 600 to 1,200 milligrams a day. Can you do that with over-the-counter products? Well, yesterday I did some internet shopping and found these apparently reputable dealers, and these are the pricing. So if you want to hit the target of 800 milligrams a day for a month, then you're looking at 2,400 or 2,200 a month. So it's prohibitive. Meanwhile, if one wants to spend that kind of money, I will refer you to this drug called Epidiolex, which is amazing to me that they got a patent for a generic drug, but nonetheless, a pharmaceutical company holds a patent to pharmacologically pure Cannabidiol. That will run you with GoodRx coupon $2,900 a month, but at least you get pharmaceutically pure material. Epidiolex, by the way, is approved now for the treatment of some forms of epilepsy, and the company that makes Epidiolex has clinical trials of Epidiolex as a treatment for schizophrenia. So more to come on that, and the Cannabidiol is currently we have very mixed results, but we're going to get more data, and stay tuned. It'll be an interesting story to follow. Turning now to diet. When people look at dietary habits of people with schizophrenia, they find not infrequently very poor diets, and this may explain why you occasionally, in the very few studies that look at vitamin levels, they usually come up with eye-opening, jaw-dropping deficiencies of vitamin levels in people with schizophrenia. As recently as the late 1980s, a study showed that amongst longer-term care individuals in Great Britain, 1/3 of them had deficiencies of vitamin C, if you can imagine that. So that may be reflecting a poor diet. It may also be reflecting the fact that they somehow are consuming that and not replacing it. It's an issue. So diet is worth paying attention to. I'll show you this study from the 1960s looked at a simple design. People with acute exacerbation of schizophrenia were admitted to the hospital. They went to one of 2 locked wards. One was standard diet ward. One was where the diet was grain-free and gluten-free. Grain-free and dairy-free. The rationale at the time was that grains, if you look at epidemiological data, there was a signal for excessive grain in the diet as being associated with higher incidences of schizophrenia. Better phrased, when grain components of diets went down during periods of famine or war, schizophrenia incidence went down. That was actually the rationale for looking at grain as a suspected agent back in those days. And the dairy was really kind of an add-on. They just thought, according to the rationale at the time, dairy products might function as sensitizers to whatever grain grain bugs were present. So nonetheless, that was how they designed it. And then they looked at a very simple outcome. You were admitted in an acute phase of psychosis to a locked ward for safety when symptoms had declined to a level that it was by consensus thought safe to move to an unlocked ward. This again was back in the days where you had these longer stays and such places existed. That was the endpoint. Time to symptom reduction to the point that one could be moved to open ward. And they found that the special diet ward had about 50% acceleration of meeting that endpoint. They also, you could do this in the 60s as well, without notifying people, put some gluten in the diet, and then they found that the symptoms came back pretty fast. So that's, again, an interesting finding. Really didn't get replicated. I mean, nobody reported follow-up studies to either support or negate that finding, so that just sits out there as an open question. I'm going to turn now to a couple of reports about a ketogenic diet that is gaining popularity these days. It's kind of the latest version of an Atkins diet. Ketogenic diet is an extremely low carbohydrate diet. It shifts the body into ketosis because most of the energy comes from fat. As folks in this audience probably know, ketogenic diets have been used to treat epilepsy for about a century. And, 21st century analysis of ketogenic diet data still come to the conclusion that it is viable, it is an effective treatment. So it's a neurologically active or neuroactive intervention. And to my way of thinking, I mean, why I started to look at this question is because many drugs that are anticonvulsants also have interesting psychotropic properties like reducing manias and psychoses. So I started to look at that and found not very much, but here's what I found. Also in the 60s was a study conducted in Sweden where they looked at 10 women with chronic and persistently symptomatic schizophrenia. They were given a ketogenic diet and found on average the psychosis severity was reduced, and it came back when the diet was stopped. There was no control group in that study. There was a case report of a 70-year-old woman, I believe, with nearly continuous hallucinations since age 17. The rationale, according to the case report, the woman was interested in losing weight and started to eat only salad and tomatoes and non-carb things, and she had a spontaneous remission of her hallucinations, and she maintained that remission for as long as she had the very low carbohydrate diet. In a case series consisting of 2 individuals with schizoaffective disorder, there was both individuals had a significant reduction of PANSS symptoms, and in both cases, the PANSS scores went back up when they went back onto standard diet. And then there was last case published this year, a case series of fraternal twins from Ecuador. Twin number 1 in the pair began to have psychiatric symptoms at age 14, and both were very symptomatic at the time that they were engaged in this dietary study. Both had small decreases in PANSS scores, around the order of 8 PANSS points, and both had resumption of symptoms when they went off the diet. So to conclude then, there's never going to be a whole lot of data on any of these topics because there is, in the current way that we do studies, very little incentive to conduct them. Nonetheless, you've seen some evidence that there may be some signal for some of these approaches, signal for efficacy. It's quite possible that responders to a particular intervention are going to be just a subgroup of the total population. So a ketogenic diet may work for randomly selecting a number, 25% of people with schizophrenia, and not for the majority. But selective responding, is something we see all the time in medicine. So if as a practitioner, one counsels to use such a treatment, or if a patient is trying it for themselves, just be very clear on what the endpoints, what are the target symptoms, and monitor them. Continue things that work and stop things that don't. Always look for paradoxical reactions to any treatment that is engaged. So that's all I have for prepared comments on that topic.